This recording will go over Chlamydia trachomatis. It's an intercellular bacterium and is the causative agent of cervicitis, which is inflammation of the cervix, urethritis, inflammation of the urethra, and proctitis, inflammation of the prostate. Chlamydia trachomatis is reportable to local health departments in all states. It's the most frequently reported bacterial sexually transmitted infection. Because it's frequently asymptomatic, the estimated incidence is approximately double of what's reported. Significant health disparities exist between racial and ethnic groups. Prevalence among non-Hispanic blacks is 5.6 times greater than the prevalence among non-Hispanic whites. There's also a high prevalence of rectal and pharyngeal chlamydial infection among men who have sex with men. Remember to use a non-judgmental approach and provide privacy and confidentiality when assessing your patient. Get a complete history, including a genitourinary system review, psychosocial history, and sexual history. In particular, ask about the presence of symptoms, including vaginal or urethral discharge, dysuria, which is painful urination, pelvic pain, or any irregular bleeding for women. Ask about a history of STIs, whether current or past sexual partners have had symptoms or a history of STIs, whether the patient has had a new partner or multiple sexual partners, and also whether the patient or a current or recent partner has had unprotected intercourse. Ask men about dysuria, frequent urination or discharge, which may indicate urethritis. He may report a mucoid discharge that is more watery and less copious than what is expected with gonorrheal discharge. Some men have the discharge only in the morning on rising. Complications of untreated chlamydia in men include epididymitis, prostatitis, infertility, and Reiter syndrome, a type of connective tissue disease. Men may report penile discharge, urinary frequency, and dysuria, while many women have no symptoms. Those with symptoms may report mucopurulent vaginal discharge, typically yellow and opaque, urinary frequency, and abdominal discomfort. Cervical bleeding from infected, fragile tissue may present as spotting or bleeding between menses and frequently after intercourse. Complications of infection with chlamydia include salpingitis, which is inflammation of the fallopian tubes, pelvic inflammatory disease, and reproduction problems including infertility, ectopic pregnancy, and complications with the newborn that is delivered. Diagnosis is made by sampling cells from the endocervix, urethra, or both, easily obtained with a swab. There are also genetic tests. Nucleic acid amplification tests are the most common method of detecting chlamydia in endocervical samples, urethral swabs, and urine. Retesting after 3 months is advised in order to detect repeat infection. All sexually active women 25 years old or older, and all women older than 25 years with a new partner, multiple partners, or a partner with an STI should be screened annually for chlamydia. Routine screening is not recommended for men. However, screening should be done with sexually active younger men, especially those who have sex with men. The treatment of choice for chlamydia infections is azithromycin, usually given in a single dose at the time of initial visit with the healthcare provider, or doxycycline. The one-dose course, although more expensive, is preferred because of the ease in completing the treatment. Directly observing the patient taking the medication in the healthcare setting will assure you of adherence. Sexual partners should be treated and tested for other STIs. Expedited partner therapy, or patient-delivered partner therapy, shows signs of reducing clinical chlamydia infection rates. Expedited partner therapy involves treating the sexual partners of patients diagnosed with chlamydia infections or gonorrhea by providing prescriptions or medication to the patient, which they will take to their partners without the partners having to be examined by the provider of care. Evidence shows that when the patient gives the drug to the partners, rates of infections decrease and more partners report receiving treatment. As with all STI diagnoses, patients and partner education is crucial. Want to teach about the sexual mode of transmission, incubation period, the high possibility of asymptomatic infections and the usual symptoms if present, the need for antibiotic therapy for the infection and the need to complete all medications even if feeling better, the need for abstinence from sexual intercourse until the patient and partners have all completed treatment, 7 days from the start of treatment, including if treated with single dose regimen. So even if they just did the one dose, they still want to wait 7 days from the start of the treatment. The need for women to be rescreened for reinfections 3 to 12 months after treatment because of the high risk for pelvic inflammatory disease. Men can also be rescreened. The need to return for evaluation if symptoms recur or new symptoms develop. Most recurrences are reinfections from a new or untreated partner. And finally, complications of untreated or inadequately treated infections, which may include pelvic inflammatory disease, infertility, ectopic pregnancy, or newborn complications.